Hello and welcome to Oncology.TV News. I'm Steve Highsmith. We focus now on the 2011 National Surgical Adjuvant Breast and Bowel Project Cooperative Group Meeting, or NSABP. Oncology.TV is there, and we have the opportunity to speak to Dr. Thomas Julian regarding a few protocols. One in particular is the B-39 RTOG 0413, titled A Randomized Phase 3 Study of Conventional Whole Breast Irradiation versus partial breast irradiation for women with stage 0, 1, or 2 breast cancer. Dr. Julian, welcome.
Hello, Steve. It's good to be with you today, speaking from the national meeting of the NSABP here in Boca Raton, Florida.
Well, describe for us, please, the B-39 RTOG 0413 study.
Right. NSABP B-39 RTOG 0413 is our phase 3 trial, which is comparing whole breast radiation therapy to partial breast irradiation therapy. And inside the partial breast irradiation arm, patients who are randomized into that portion of the study are allowed to be treated either with multi-catheter brachytherapy, 3D conformal external beam therapy, or a intracavitary balloon brachytherapy type device. That trial has a target accrual of 4,300 women and is been open since March of 2005.
What can you tell us about the rationale of the study?
Well, the trial is based on the rationale that there is the potential that you do not need to treat the entire breast with radiation therapy. There is very early data over the last decade which has shown that for very good prognostic tumors, those that are small in size, those that have negative nodes, there may not be the need to treat the entire breast. There has been some institutional series of small nature that have shown that patients who have limited radiation therapy to the breast have a recurrence rate of tumor in the breast that is equal to women who receive whole breast radiation therapy. And that actually is the primary endpoint of the study in breast tumor recurrence. We know, based on data from NSABP B-06, that had patients that were randomized to lumpectomy, lumpectomy with radiation therapy, and mastectomy, that in the lumpectomy only arm, the majority of recurrences came at the site of where the tumor had been located. And that even happens in the patients who receive whole breast radiation therapy. So the rationale stands the fact of saying that if the majority of recurrences only occur where the tumor was previously located, then why treat the other portion of the breast, put it at risk for injury from radiation therapy, when limited radiation to the tumor bed may be all that is needed to maintain a good outcome and keep a low in-breast tumor recurrence. So for that reason, this trial was put together with both the NSABP and RTOG and was sanctioned by the NCI and was open in 2005. And we have had a rather good accrual. Currently, we are just about 90% accrued in the study. We are going to make some modifications into the study to allow some different intracavitary devices to be utilized to essentially kind of expand what's happening in the community setting and make it maybe more feasible for patients to be part of the study. And patients to date have been doing very well. We have a very low toxicity related to any forms of the radiation therapy that are being used. And that is a very strong positive point of this study. And of course, the primary endpoint ultimately will be to look at in-breast tumor recurrence. Our other endpoints, our secondary endpoints, will be overall survival, disease-free survival. Patients who are eligible for this trial are patients who have a tumor that is 3 centimeters or less in size, who have positive nodes, up to 3 positive nodes, and also we are entering patients who have both DCIS and invasive breast cancer. There is some modification that occurred in 2007 because of the necessity to concentrate on a higher risk population of patients, and that required us to focus on younger women with DCIS, patients who were node positive, node negative in the younger group meaning younger than 50, and in the patients over 50 to concentrate on patients who had positive nodes or who were estrogen receptor negative.
Dr. Julian, comment please on the outcomes or any potential results to date.
Well, unfortunately, the only outcomes that I can give you at this time are related to toxicities, and those are really not outcomes. The toxicity levels in both arms of the study are extremely low. Patients receiving whole breast radiation therapy or a form of the partial breast radiation therapy, and they are very acceptably low. It's being monitored by our data monitoring committee, which has been very, very compulsive about oversight and making sure that we are protecting our patients and they are being treated as per the protocol guidelines. As far as information related to in-breast tumor recurrence and survival and disease-free survival, we will not be seeing that data for many years yet because we're probably going to be looking at a point down line of somewhere in the neighborhood of about 10 years.
If a physician has a patient interested in this trial, where should they go to find out more information about enrolling?
Well, patients can enroll, obviously, if they're at an NSABP site through the NSABP investigators. If they are at a RTOG site, they can enroll through the RTOG investigators. If a physician has a patient and that physician is not connected directly with NSABP or RTOG, they can actually enter a patient, or that investigator can enter a patient through the Clinical Trials Study Unit, the CTSU, or they could refer the patient to an NSABP site or an RTOG site.
Dr. Julian, thank you for the update on B-39. Would you also update us on the B-43 trial?
NSABP B-43 is a clinical trial which is focusing on women who have ductal carcinoma in situ, or more commonly called DCIS. These women who are undergoing a lumpectomy for the tumor and who will be going on to receive radiation therapy can enter the trial. We're actually looking and concentrating on ductal carcinoma in situ, which is actually HER2 positive as a molecular marker that it carries. So the tissue that is removed from the breast is then sent off to have an analysis for the HER2 positive state. If it is HER2 positive, the patients can then be entered and randomized into the trial, and when doing so, half the women will receive 2 doses of Herceptin during the radiation therapy. The other half will just receive their radiation therapy. The rationale for this is that we are looking at a high-risk population of DCIS and using Herceptin to sensitize the area to enhance radiation therapy to lower the in-breast tumor recurrence. And we know that historically, high-risk DCIS lesions, those that have been associated with comedo-necrosis or those that have been ER negative, have a overexpression of HER2 positive status. Therefore, this makes a very excellent molecular targeting opportunity for us with the use of Herceptin. There has been early laboratory data which has shown that tumors in animals that were HER2 positive, if they received Herceptin during the radiation therapy, actually had a higher rate of disappearance than tumors that were just subjected to radiation therapy in the laboratory setting. So the patients, once they have their tumor resected, the investigators at the site can consent the patients to have the tumor sent off for HER2 analysis. And again, if it's positive, there's a reconsenting so that the patient can then be entered and randomized into the trial if they agree to proceed. It's felt that the 2 doses of Herceptin, which are given 3 weeks apart during radiation therapy, is a very safe application of the Herceptin. Toxicity issues should be very, very low, and has not generated a high level of concern by groups such as the NCI and our central IRB who help oversee this trial. The trial is going along fairly well. We've learned by looking at some of the testing that roughly 1/3 of the patients are actually found to be HER2 positive and can enter into the trial. So it is we think a very great opportunity for women who are at higher risk for potentially having their invasive cancer come back after having a lumpectomy and radiation for their DCIS. This is a trial that is obviously sponsored through the NSABP as well as the NCI, and has also been endorsed by RTOG.
Where are you with the accrual of this study, and are there any preliminary results to date?
This trial has been open since November of 2009 and is roughly 1/4 of the way through its accrual process. We have a very long time yet ahead of us before we can actually have data about the in-breast tumor recurrence, and that is the primary endpoint. I can tell you in its early phase right now that toxicity-related issues are almost non-existent with the patients on either side of this trial arm setup.
And if a physician has a patient interested in this trial, where do they find out information about enrolling, and is there any special consideration they should know about?
If a physician has a patient who has DCIS and they are interested in enrolling the patient into this trial, and if the investigator is not part of NSABP or RTOG, they can enter a patient through the CTSU mechanism. Or if they choose to do so, they could refer the patient to an NSABP treatment site or an RTOG treatment site and have the patient interviewed and to see if the criteria are correct for the patient to enter into the trial. Once that happens, then the patient can go in. The one special item on this trial is the fact that we do have to have centralized testing of the DCIS to ensure that it is HER2 positive. And currently that centralized testing is being carried out at Rush Hospital, Rush Memorial Hospital in Chicago.
Dr. Julian, thank you for your informative updates on both studies.
Steve, as always, it's been a pleasure to speak with you about our clinical trials. Thank you.
I'm Steve Highsmith. Be sure to watch more video coverage from NSABP 2011 right here on OncoView.tv.